Hi again, everyone. I would like to just remind you this channel is for your education purposes. It does not replace any medical interaction. It does not replace consultation, diagnosis, investigation, and treatment. But what I'm really hoping it will do is help guide you, help get you to ask the right questions, help get you to seek the right help for you in your heart failure journey. So today I am talking about one of the big newcomers to drug therapy for heart failure, and that is Entresto. Entresto is a combination of two drugs. It's a combination of a drug called valsartan, which is an ARB, which for those of you who don't know what that is, it's angiotensin receptor blocking agent, and that drug and that type of drug have been around for many decades now. But there was only one that ever got trialled that was said to be useful in heart failure, and that was candesartan. But since then, the makers of valsartan came up with a unique concept to combine that drug with a neprilysin inhibitor. And that's how they came up with this new class of drug called an ARNi. So angiotensin receptor neprilysin inhibitor. What a mouthful. Anyway, all you need to know is that it now blocks or potentiates different aspects of the hormone cascade that affect heart failure. When we're using drugs to modify what's happening in the body with heart failure, we're doing things like blocking the stress hormones, blocking the hormones that affect our blood pressure, our salt and water retention, very importantly, and other aspects. And this one is quite unique because we had never seen anything like that. They tried a few variants in the beginning that didn't work. In fact, they actually started with an ACE inhibitor and the neprilysin, and that actually caused too many adverse effects, particularly things like anaphylaxis, throat swelling, difficulty breathing, that kind of picture, which was clearly not a good thing to do and not very helpful in this condition. And when they then got onto this ARNi combination and evaluated this drug in heart failure, they did it in a fairly large population, and they got staggering results in reduction in mortality. And that was in a trial where it was tested against a placebo, tested with the standard of care therapy. So what that says is they took the standard of care for heart failure and then they added to it, or in another arm used placebo, so that they could really evaluate whether or not this drug did anything above and beyond the standard of care. And what they found was it reduced mortality substantially. But in the beginning, they also determined that it couldn't be given in a sort of an acute heart failure setting because it was possible that might destabilize the patient in that situation. So instead what they did was they got patients who were acutely unwell, they stabilized them first, and then they did a swap out of their either ACE inhibitor or angiotensin blocking agent and swapped it in the new ARNi drug at a low dose, and then scaled that up gradually as tolerated, and then followed them over a long duration of time, looking for things like, was their heart failure better? Did they stop bouncing into hospital as much? Did their heart failure improve? Did they survive? So they looked at things like cardiac events, heart failure, heart attack, and death. And the end results of this were extremely positive, extremely in favour of this new class of drug. So then a few years ago, this was added into the standard of care therapy for heart failure patients. Now, there are a couple of caveats to the use of this drug. If you are already having have had an adverse reaction to any ACE inhibitor or ARB, then this drug is probably out for you, sadly. If you have severe kidney issues and your kidney function is not good, then also this drug might be out for you. This drug will also tend to be a little bit more aggressive about lowering blood pressure. That can be an issue, especially for a lot of heart failure patients who already have lowish blood pressures to begin with. And this one does seem to be a little more aggressive than the other tablets that we could use in that category, but not with the combination. And so therefore, that can be also a limit in terms of its use. So I think in my clinical experience, I found this drug to be really effective. I've had some very, very good results with it. But I have found also the odd patients where I've had to reduce the dose, even when we may have successfully gotten up to maximal therapy. Sometimes at some point we've had to pull back, and that's often because of blood pressure issues. Occasionally it's because of kidney issues. It's not suitable for everyone, but certainly for those patients who seem like they could tolerate it well, I'm an advocate for commencing this medication, and often in favour of the previous ACE inhibitors or ARBs available. If someone is super stable on their current therapy and they're doing very well, then it's a conversation. You know, here is this drug, here's what it might do for you, here are the possible downsides. There are a lot of similarities to what you're on, but some advantages if you can tolerate it, and you know, is that something you want to try? That kind of thing. So that's the new class of drug, ARNi, ARNi, in case you were confusing that with Arnold Schwarzenegger. No, not ARNie. But, you know, kind of maybe it's a super powerful drug, so maybe that's not a bad alignment, really. But that's ARNi in a nutshell. There are, of course, many more things you could know about that drug if you wanted to, like all of the drugs we've discussed, but I've tried to keep this fairly simple, fairly light on any technical jargon, so that you can understand the point. Like all of the heart failure therapy, however, we are aiming for maximal tolerated dose, not just a little bit. So, you know, if you're wondering why heart failure specialists keep sort of adding to the drugs and keep adding to the doses, we know very clearly from the drug trials that more is better in this instance. It's a little different to treating cholesterol or treating blood pressure, where you have very easily defined and measurable targets that you can look at. In heart failure, we don't want to wait for you to die to know if we did the right thing in the first place in terms of our dosing. We've taken information from the trial data to evaluate that, and it is very clear from the trial data that patients who are on maximal tolerated doses tend to do better than those who are only on small doses or none at all. And there is plenty of data out there to show that many patients aren't on sufficient heart failure therapy, if any at all, sometimes. And that's a clear blight on perhaps systemic forces, perhaps availability, perhaps cost, perhaps accessibility. And one of the clear relationships, I think, is whether you are able to find a heart failure specialist, one that knows these drugs well and knows the benefit of being on the highest doses possible. And look, by highest dose possible, it does depend on a lot of individual factors. So, what you're on might not be wrong at all. It might be what you can tolerate, and that's okay. And people can do well on less. It's not to say you can't, but the aim is maximal tolerated. So, ARNi, really important drug that came in a time where it had been a while since we'd seen something really novel and really efficacious in the field of heart failure, and certainly a welcome newcomer. And so that's it for the ARNis for now. And next time we are going to talk about the little diabetic wonder drug that got released in the last few years and added to our sort of staple core drugs to put heart failure patients on. And so we're going to talk about that one next time. So look forward to having you join me then. Bye for now.